Alright everyone, so today we're going to be covering pediatric GI disorders. This lecture I'm going to try to hit some of the highest yield pediatric GI complications, both in the baby, the young adult, adolescent. I'm going to try to hit those. There are going to be some topics that I've already covered in other lectures, such as celiac disease and IBD, but I will go through what I can during this lecture. Here are your instructional objectives. You will notice that there are some instructional objectives from the Helminth lecture, which I covered on another day. Here's our topic outline for today's lecture. You'll notice that we are covering a lot of different disorders and a lot of ground, so we're going to try our best to kind of go from one to the next. First, we're going to talk about the approach to the pediatric patient, kind of how to gather a good history, do a physical exam that are pediatric centric. Then we're going to move on to abdominal pain in the pediatric patient. We're going to talk about constipation, diarrhea, vomiting, and fluid replacement in pediatrics. And we're also going to mention failure to thrive. Then we'll move on to some of the more specific pediatric disorders, some of which I will go in more depth than others. And that's how we'll finish up the lecture. So if you're fortunate enough to have kids of your own, nieces, nephews, or you've been around kids before, you know that they are their own unique human being, right? Pediatric patients, you have to treat them like kids, right? Different from adults. And so I wanted to talk a little bit about how to approach that patient, a little bit from experience and from some research. So children, they compare children, seeing children or being a pediatrician or pediatric PA to being a veterinarian, because dogs and cats and animals can't tell you what's wrong with them, and a lot of times kids can't verbalize what exactly is going on with them. But if you pay attention to details, pay attention to nonverbal cues, and to what mom and dad are telling you, should be able to get a good history and have at least an idea of how to work up a pediatric patient. They have other signs that are not specific. Like, they don't have to tell you, I'm not hungry. You have to pay attention. Are they eating? Are they wanting to play? Are they irritable or fussy? And then at the later stages, somnolence. So on either end of the spectrum, whether they're really, really irritable, crying for everything, can't be still, or they're completely somnolent, those are all indicators that something is going on. When you walk into the room of a pediatric patient, the first thing you should be doing is observing the child, and you're trying to observe them in a more natural environment. It's sort of like when you go to the zoo and you look through the glass and you can kind of see them in their own environment. You don't want to intrude on that, because then you might change their natural behavior. So the first thing you want to pay attention to, how is he walking? Is he playing? Is he climbing on the furniture in the room? You know, what are those clues telling you? Also, when we deal with kids, we're not just dealing with the kids, we're dealing with their parents too. And as I mentioned before to y'all, parents care a lot about their children in most cases. And so they have a lot invested in them. It's a little piece of their heart. So you're going to notice that parents are very, very eager to get your attention, to make you know that something's wrong with their child. And a lot of what you gather as far as history is subjective to the interpretation of what that parent believes is wrong. So you have to take everything they say kind of with a grain of salt, but at the same time, you should never doubt a mother's intuition, because it's hardly wrong. And I'll give you an example of this. I work in the ER. I get a little baby, maybe 1.5-year-old, comes in, and mom tells me that he has a sore throat. And I'm thinking to myself, of course, in my head, how do you know he has a sore throat? Did he tell you? He can't even talk, you know? But, you listen to the mom, she tells you everything. And sure enough, I do an ENT exam, look at the back of his posterior pharynx, and it is red with pus. And I'm just thinking, mom knows best, So definitely listen to the valuable information that parents, especially a mother, can give. So let's talk about the approach some more. Abdominal pain can signal disorder with greater severity and different associated signs than adults. So it's not going to be the same. Appendicitis, for example, has higher rupture mortality rates, and vomiting may be the only other sign. It might be different. It's not the classic right lower quadrant pain with high leukocytosis and vomiting. It might be a little different. I think we did discuss that, in class with some cases that have come up. Also, pyelonephritis can cause abdominal pain, not necessarily the classic urologic dysuria and things like that. You can get abdominal pain from multiple different etiologies. The differential is very long, and I have a slide on that coming up. You also have to consider that kids, they know how to get what they want. They can be quite manipulative if you allow it. And so sometimes kids can use the complaint of abdominal pain to reflect an emotional need, such as attention, even though it is kind of a negative attention. Some kids can use that as an excuse to not want to go to school or to avoid going to school. When we get a history, remember, most of our history we're gathering from the parent, but we want to get a more comprehensive history in most cases, including prenatal, all of the prenatal care, whether everything was routine, and the birth history, whether it was via vaginal delivery or C-section, at how many weeks was the child born, some developmental history, which we'll go into a little bit more throughout this lecture. But babies in their first year of life have many routine visits to the pediatric office to check for those developmental milestones, to make sure that they're growing and that they are growing, essentially, both physically and with the things that they're able to do, like rolling over, crawling, walking, etc. Also want to consider social history of the family, any environmental risks. And the good thing is that a lot of these risks, such as, say, lead poisoning or things like that, are covered in the questionnaires that are given to parents at these intervals with their well child checks. Also very crucial, every single patient as pediatric that I have, I ask about immunization history. Again, we are considering that the parent is the primary historian during an encounter with a pediatric patient. It's their interpretation of how the child is feeling. So if the parent tends to be a bit more, I don't like to use the word dramatic, but more empathetic, they might, perceive the child's pain or discomfort as more than it actually is. Or if they're more of the suck it up kind of parent, they might be underplaying the child's pain. So pay attention to that. Kids, as soon as they start to be verbal, it depends on the kid, of course. Some are more willing and eager to share than others. Some are more shy. You can start getting some of the history from them, asking them, including them in it. Of course, this is information you're gathering from the perspective of a small child, so you have to kind of compare it to what your eyes and your ears and your hands are seeing and feeling in the moment. Try to ask questions without leading the parents on. There's certain ways and techniques to asking those questions, which I'm sure you'll cover in patient encounter. You also want to observe the parent-child interaction, right? Because parents, especially if the child is really needy, clingy, crying, it's going to be hard for the parent to answer questions appropriately. And also you want to just note, in your brain, the quality of the relationship. Is the mother or father soothing to their child? Are they listening when the child talks to them? Do they have good discipline with the child? That kind of thing. And then, of course, whenever you have a kid, they do not give you a guide. They don't give you a book with your child. This is the starter manual. Here's what to do in every situation. Being a parent is difficult and it's dynamic. Your child is constantly changing, growing, and so are you as a parent. So there's a lot of guilt associated with illness in children, especially their kid. And so you want to definitely approach the parent with a very non-judgmental and reassurant nature. Also, parents, that their child is everything to them. So sometimes you notice that they might be more irate if they're not getting what they need for their child. So it's just have to communicate really well with parents. In addition to a thorough HPI and past medical history, pediatric history should also include, like we mentioned, pregnancy and birth history. We talked about this a little bit already. Also, developmental history. We also mentioned this, ages at milestones are achieved. Smiling, rolling, sitting, crawling, all of those need to be documented in the well child visits. Also, as children get older, noting, when they start to read, whether they're having any trouble with interacting with their peers, anything like that, and then behavior issues. Feeding history, especially in the child, younger than 1 year of age, you're going to want to get a really good feeding history, whether they're breast or bottle fed, what types of formula they use, how often they're eating, how much they're eating, and any changes in formula and why they changed. Also, once parents start introducing solid foods, or anywhere between 4 or 6 months of age, you want to know, what they're introducing. Recommend that parents introduce one food at a time for a period so that you can keep track of any problems that are associated with specific foods. So what I like to do when I walk into the room for a history and physical on a kid is I walk in, and if the kid is kind of doing their own thing, I kind of let them do their own thing. Especially if they're really young and I'm concerned that my presence might cause them to become anxious or kind of change the nature that they have. So I observe, what is the kid doing? Are they on the furniture? Are they eating? Are they playing? Or are they laying still? Are they in mom's arms? Observing as much as possible before I just dive in. Keeping an eye on where the child is. Now, usually I try to do a lot of my physical exam in the lap of the parent because that's where the child feels most comfortable. So a lot of times I'll do an ENT evaluation, listen to heart and lungs, and extremity evaluation in mom or dad's lap. And then if I need to do a more comprehensive, say, abdominal exam or rectal exam or anything, I'll move them to the exam table at that point. If you can, try to avoid wearing your white coat in the room with a pediatric patient. It tends to kind of automatically scare them. And try not to tower over them, just like they say, you try to get down to their level and talk to them as much as possible, so to try to show them that they can trust you. I don't know if you remember back when you were a kid or taking your own children to the doctor. They have to go quite often, and a lot of their young years are spent getting immunizations. So they associate medical personnel with immunization shots, and so they are very distrusting of us. So do your best as a provider to try to gain that trust early on. When you're doing an exam on a child, try to do the least distressing first. So don't go straight for their throat when you know that's going to make them cry and gag. Try to do some things that you can do, kind of working your way up to the more distressing exams. Try to include the child if they're willing. I like to talk about, what kind of t-shirt they're wearing, if they like the Ninja Turtles, what's their favorite turtle, kind of distracting questions, and also just showing them that you care what they like and things like that. Also, there's, lights you can use. Their gloves. I always see the parents getting the gloves off the wall to entertain their kids. But either way, find something that works for you. Again, just like we did the least distressing to most distressing, same thing when we examine painful areas, we want to leave that for last, because we can get a good impression of everything else and then go for the area that's hurting them the most. If something is going to hurt, if you're going to give them something that'll hurt or give them injection, it's best to be honest. If you lie to a child, you'll likely lose your credibility for the rest of the visit. And so another thing is just, being mindful of where a child is in their development. There is such a thing as stranger anxiety. And, just try your best to try to make ends meet with the parent and the child. So vital signs, we have mentioned this before. Vital signs are different in pediatric patients. Their normal values differ, and they are related to the age. You should always refer to a pediatric vital sign normal chart to assess the vital signs. As far as temperature, in the emergency department, if a kid is coming in with a febrile condition, we tend to rely on the rectal temperature. It's the most accurate, although there are many other ways of assessing temperature. There's tympanic, oral, axillary. Heart rate. For babies, you can feel the apical pulse or the femoral pulse, and otherwise the antecubital radial pulse in older children. Most automated machines that assess for pulse oximetry also check the pulse, although those don't necessarily work as well in tiny babies. Respiratory rate. You do, in pediatric patients, you can't just count 15 and multiply it. You have to count for the full minute, because especially babies have this periodic breathing where they kind of breathe fast a few times and then they kind of have lapse and then they breathe some more. So you can't get a good number unless you count for the full minute. Blood pressure. You want to make sure that the cuff is appropriate size for the patient. We don't always assess blood pressure in tiny patients unless we're concerned about hypovolemic status or things of that nature. And then growth parameters. So in the emergency room, we don't necessarily plot on the growth curve, but we do get height and weight. We have to get those things to help us calculate medications. In the pediatric clinic, you'll want to get the height, the weight, and then the OFC, and you'll plot those on the growth curve and keep an eye on that. Looking more into the pediatric abdomen, so most younger children tend to have more protuberant abdomens, which is more prominent. As the child grows, it becomes more flat, scaphoid. We want to take note of the umbilicus, looking for any infection. Kids like to pick at their belly buttons for some reason. Also, children can get umbilical hernias. You're looking at the muscular integrity. Diastasis recti is kind of a bulging of the area along the linea alba. This is the abdomen. There's the belly button and the legs. And you'll see kind of a diastasis where when they sit up, or valsalva, this little area will pooch up. You're also looking for scars. Listening, you want to try to keep the patient as quiet as possible so you can get good auscultation. Best way to do that is either try to listen in mom's arms with a pacifier. You can give them a bottle or something to kind of soothe them and keep them quiet. When we palpate, palpation of the abdomen, I always try to do it on the bed. I don't trust a child sitting up trying to do an abdominal exam. If they do tend to have a tender area, try to save it for the end. Because children are so small, you can almost touch, the retroperitoneal with your hand without applying too much force, so you can feel for, fullness in the bowel from constipation. It's a little bit easier to assess. But it is harder in some sense because children have a hard time allowing palpation of the abdomen, and so it can be difficult to ascertain whether it is, because they're ticklish or because it hurts. So there's other things we can do to try to assess for, say, rebound tenderness. Can have the child kind of get up and jump up and down on one foot. And this little diagram here shows some of the areas of the abdomen and kind of the more common etiologies in those areas. This chart has a lot going on in it. I don't expect you to memorize the whole thing, but it is helpful, I think, into looking into what some of the common non-traumatic causes of abdominal pain are in kids, when they tend, who the demographics are, what the history looks like, physical exam findings, and imaging studies. Many of these we will talk about as we go through this lecture. However, if you like kind of an all-encompassing chart, here it is. All right, so now we're going to go through a few of the more common pediatric chief complaints, and try to talk a little bit about how to approach a pediatric patient with these chief complaints. First, we're going to talk about constipation. Now, constipation, like we talked about in adults, is a relative term. So it's hard to quantify what constipation means to every person because every person has a different normal bowel movement. Now, a couple of things that are consistent with constipation are the frequency, how often we're having a bowel movement, the consistency, whether or not it's hard or soft, and how much difficulty we have passing the stool. So a hard stool is passed every third day with difficulty and requires management. A soft stool that's passed with every difficulty every 2 or 3 days is not necessarily constipation. So you have to put those pieces together to determine it. There is kind of a consensus of trying to decide what defines constipation. And here are some of those things. But I think most of what we gather from our parent and our patient is historical, and we can kind of put those pieces together and make that diagnosis. Constipation affects up to 30% of children, so it is a very common chief complaint. And functional constipation without any specific organic cause constitutes 95%. And the most common we see is preschool, so 2 to 4 years of age. So functional constipation, we just talked about it. Functional constipation means it does not have a true organic cause. So here's some of the organic causes, things that we can put our finger on that cause constipation. There's some anatomic defects, there's abnormal musculature, nerve abnormalities, metabolic disorders, intestinal disorders, drugs, and psychiatric disorders that can all contribute as organic causes to constipation. However, we know that functional constipation or constipation without any organic cause is the most common cause of constipation. And there's kind of this little vicious cycle that goes. So a lot of times it has to do with the diet and the amount of liquid that the child is consuming. It leads to a hardened stool. That hardened stool is then more painful to pass. So because children sense that bowel movements are associated with pain, they try to hold their stool. When they hold their stool, they accumulate more stool in the rectum, and that causes further hardening of the stool, which then reduces the sensation to defecate, that reflex that we have, and it's less effective peristalsis, so it's not helping us push it out. And so then what happens is because younger, this is usually the 2 to 4 age group, because these children are holding their stool, they get to the point where they can't hold their stool, and you get this passage of this watery content that goes around the compacted stool, and then these children can be mistaken for not having constipation but actually having diarrhea. So it's kind of this cycle that happens with kids, and some kids can be really averted to having bowel movements because of this cycle. Sometimes because of the large amount of stool kind of in the rectal area, it can actually cause some urinary stasis. And like I mentioned before, it can have a real emotional impact on the patient and the family, where they can have a real fear of using the restroom. So in most cases of mild constipation, history and physical exam are performed, and really we're thinking about pinpointing any organic causes and before we can kind of blame it on just functional constipation. So we want to ask the parent, how often are they having bowel movements? What is the consistency? What is the size of the stool? Is there any pain associated with it? Or is there any blood, right? Is there any incontinence? Are they having any encopresis, right? Diarrhea or liquidy stools along with their constipation? Do they have frequent UTIs or anything like that would trigger you to think they're constipated? Does it have to do with dietary transition? So little babies and kids go through many dietary transitions where they go from formula to cereals to solid foods and then cow's milk. So there's a lot of different transitional periods that you'd want to assess to see if they have anything to do with the onset of the constipation. Also, recent illness, having little URIs, being dehydrated, or diaper rash can also affect it. Little kids are really sensitive to new. The change can really throw off a kid. Ask any parent who goes through daylight savings time every year. They'll tell you the same thing. Change is hard for little kids. And so anything from starting new school, moving, or even toilet training itself can be stressful and cause constipation or contribute to it. What we're looking for when kids are kind of holding or having trouble having a bowel movement, they'll tend to squat, they'll cross their ankles, they'll kind of get stiff in the body, or they'll kind of go off into a corner if they're still wearing diapers. They'll go off into a corner and kind of hold on to the furniture and kind of bear down over there. And you can sometimes even see their face turn red when they're having trouble. Some of the cues kind of pointing to more organic etiologies would be like a Hirschsprung's. Hirschsprung's we'll talk about a little bit later. The hallmark of that is going to be the lack of passage of meconium, which is the stool that kind of comes with the baby when they're born. It should pass within 24 to 48 hours. If it doesn't, should consider Hirschsprung's. And other things like lead poisoning can cause constipation, dietary intolerances, and things like that. Physical exam. So generally speaking, you want to review the growth charts, assess for failure to thrive. And failure to thrive essentially means that they're not growing like they should. Other things you want to look for, other syndromes like Down syndrome and other things like that, which are usually diagnosed really early in a kid's life, should be reviewed. Now, the abdominal exam, like we mentioned, you want to palpate all along the abdomen, and you're really feeling for constipation. Kids that are quite constipated, you actually feel stool on the left side of their abdomen. You also want to do a neurologic exam, making sure that they have good ganglionic action. And then the rectal exam. So by no means do we have to do a rectal exam on every child that comes in with constipation. Usually if a kid is ill enough, their parent thinks they're ill enough to bring them to the emergency room with constipation, I tend to do a rectal exam. I usually use my pinky, and I feel for, first of all, examining on the outside, looking for any pathology, fissures, fistulas, hemorrhoids, things like that. You test for the anal wink to test the nerve function around the anus. And then when you do the digital rectal exam, you're feeling at the fingertip should hit kind of firm stool, a mass, something in the rectum that might help signal constipation, like a large amount of stool in the rectal vault. And then if you do the rectal exam and you feel that it's empty and kind of tight in there, you might be thinking Hirschsprung's. And what's classic with Hirschsprung's is because it's so tight there, and you do the digital rectal exam, after you remove it, you tend to see kind of a gush of liquid stool that kind of follows it, which is classic of Hirschsprung's because it released that pressure down there. We'll talk about that a little bit more later. So how do we diagnose constipation? Well, if the child is healthy and there's really no alarm signs, no large amount of blood, no severe pain, nothing like that, then the diagnosis of functional constipation is clinical, right? My child's not going to the restroom. Everything else is pretty much normal. They have constipation. It's clinical diagnosis. Really, what we do lab work and other things for is really to rule out other things. And we don't do there's not a whole lot of lab testing that we do. If they come to the emergency room, a lot of times we'll do quick plain abdominal radiographs just to look for some stool, but it's not routine. It's not always 100% necessary. And then there's some more specific testing that can be done, although it's pretty rare that this gets done. You're looking for really specific things with this. And then we'll talk about Hirschsprung's later. A lot of this has to do with Hirschsprung's. Here is an abdominal x-ray. This is an anterior view. And you can see the large amount of fecal matter within the rectal vault. And there's also kind of fecal matter all throughout here, suggestive of constipation. So management, how do we manage constipation? Well, if it's organic, you have to manage whatever the organic cause is, right? If it's Hirschsprungs, you got to treat the Hirschsprungs, right? If we determine that their constipation is functional, then we really have to address three major components. One, we got to get the stool out of the colon. We got to get it out of there so that that the rest will, so there's not a backup. And so a lot of times what I'll order in the emergency room is a glycerin suppository. It's easy to place in there. It kind of breaks up that stool ball that's blocking the way. And that is one thing that will help kind of get things going. Sometimes it's even as simple as telling the parent to use, say, the rectal thermometer and kind of stimulate things a little bit that way. That sometimes that's all kids need to kind of go. We want to try to eliminate pain on defecation because a lot of times that's what provokes kids to hold it. And so sometimes we have to prescribe laxatives such as Miralax. We definitely recommend diet modifications, more fruit juice, more vegetables, and sometimes we have to kind of lay off the cow's milk a little bit if they're getting very constipated because of that. And lastly, we have to improve bowel habits. So sometimes we even have to do kind of regularly scheduled bowel or toilet visits. So we go, 5 to 10 minute visits to the toilet, every hour or so, and especially after meals to kind of encourage kids to go when they need to go and not hold it. As far as surgery, it is rarely needed unless there's some specific organic cause. Other things that we can recommend within the first year, if the child is breastfeeding, continue breastfeeding. It's one of the best ways to relieve constipation. I have not seen many babies that are exclusively breastfed have constipation. And then one other thing you can recommend to parents is if the kid is having kind of trauma associated with using the restroom or having bowel movements and they're kind of already a little traumatized with it, you can use incentives or reward focused behavior instead of chastising the kid, right? So kind of positive reinforcement versus negative, where you say, if you go and you try to sit on the toilet, I'll give you this little M&M or something like that, just to get them to think of it as a positive place rather than negative. Now that we've gone through kind of all of the approach to constipation, there's this little kind of flow chart that helps you kind of go through what we've talked about, where you start with a constipation, you get the history, physical exam, and you test for blood, and then you kind of keep going down this, teaching you how to do maintenance therapy, medications, and things like that. All right, so we've covered constipation in pediatrics. Now we're going to go on to diarrhea. And as you know, we've covered diarrhea in the adult population, and a lot of what we've covered in the adults translates to kids. So we'll try to highlight some of the major differences and use it as kind of a recap, right, of what we've already learned. So diarrhea, as definition, is excess stool output that is often loose or watery. Okay, and there are specific guidelines for exactly, how much quantifies excess, right? And there's some hard and fast calculations here, although I don't think we are going to measure in a measuring cup exactly how much stool this child is putting out. Can kind of take it for what it's worth. Usually greater than or equal to 3 loose watery stools per day is sufficient to diagnose diarrhea. Now, like we mentioned in our adult lecture, there's a couple different ways to classify diarrhea. The first is by classifying the timing, when it started. If it started 2 weeks or less, we consider that acute. And usually greater than about 4 weeks is considered chronic, with the 2 to 3 week period being kind of intermediate. But as far as this resource, it's mentioning that greater than 2 weeks is considered chronic. Okay. That's one way to assess for diarrhea. Another is to look at the type of diarrhea that it is. We have some major types. Inflammatory is one. Then we have kind of the more non-inflammatory, which are the osmotic, the secretory, and motility related. So here in the United States, we kind of got our diarrhea under control but throughout the world, acute diarrhea is most common, and it's associated with quite a few morbidity and mortality, right? They get chronic diarrhea, it's more lethal, and so it can be a real problem worldwide. The most common form of acute diarrhea is going to be viral diarrhea, like we mentioned in the adult lecture. Same goes for kids. So you're going to see this quite a bit in your clinic or in the emergency room. And by far, the most common etiology, especially in the acute setting, is going to be viral. All right, so just like in adults, there is a huge list of things that can cause diarrhea. Just quickly, I have the acute on this side, the more chronic on this side. As we mentioned in the adult lecture, infectious are going to be the vast majority of the acute diarrhea illnesses, with viral being the most common. There are also bacterial enteritises. Just a quick recap: E. coli, commonly seen also in nurseries and daycare centers, similar to rotavirus. Salmonella, we see it in eggs, milk, poultry, and then certain pets, like especially reptiles and Ninja Turtles, right? Shigella, contaminated food, same with Campylobacter and Yersinia. C. diff, prior antibiotic use. Staph aureus, egg products, less than 6 hours. And then parasitic, commonly seeing among hikers, Giardia. And then crypto is generally seen with more systemic infections like HIV and things like that. Then we have for the acute some of the non-infectious causes, antibiotic associated. Hirschsprung can get infected and have a colitis syndrome. Babies that have received narcotics in utero can have a narcotic withdrawal when they're born. And then there's in older kids, these are in younger children. Older kids, again, infectious are going to be most common. And then there's also appendicitis can cause a little bit of diarrhea occasionally. Looking at the chronic, there are some infections that can appear more chronic, such as the parasitic infections, malabsorption, such as cystic fibrosis, celiac disease, those and protein intolerances. Those can be found in the younger children. Same thing with inflammatory gastroenteritis, eosinophilic disease. And then let's see, in older children, it's kind of some of the same things, but also lactose intolerance, celiac again, and IBD. We see that more here. So history. Same kind of stuff we talked about in adults. You're going to want to know if they have fever or blood, and mucus too. Any type of exposures, what they've eaten recently, suspicious foods, recent travel, antibiotic use, all of that we have to cover. Same thing in pediatrics. Usually in a virus, you can have, it's self-limited. It can be anywhere from a couple days all the way up to 7 days of watery diarrhea, vomiting. And a lot of times pediatric patients also have, if it's viral, other upper respiratory symptoms associated with the diarrhea. Bacteria, if it is enteroinvasive, we're going to see the high fevers, the stools, abdominal pain, and then Shigella can also be associated with seizures. Now, on physical exam, it is imperative that we assess for dehydration. Our pediatric population are vulnerable. They're small, and so they can become dehydrated much more quickly than their adult counterparts. So it is really important that we assess the status of their hydration. Several things we look at in regard to physical exam are going to be their mucous membranes, whether or not they're dry. Skin turgor, I'm sure we learned that in physical exam. It is a late finding if you have positive skin turgor. Then that is a more late finding of dehydration, as well as decreased capillary refill. We're also looking at tachycardia, level of consciousness, fever, abdominal exam, looking for rebound and guarding, delayed growth and weight for more chronic. You'll want to do a perianal inspection looking for tags or fissures in Crohn's disease, and the like. So, diagnosis. The workup for most cases of acute diarrhea are going to be viral, and thus a workup is not necessarily needed. It's really only needed in cases of moderate to severe dehydration. I was going to say students, pediatric patients that are immunocompromised or are septic. Those are reasons why we are going to need to get more of a workup. Or chronic diarrhea. Chronic diarrhea a lot of times is going to need more of a workup. If and when we do need to do a workup, it's going to be similar to the adult. We'll get a BMP, and that's one of the tools we're going to use to assess for dehydration. And we'll see these findings. We'll talk about them more a little later in this lecture. We also can do stool microscopy, culture. If patients have hemolytic uremic syndrome, you'll want to test specifically for the E. coli 0157H7, which is the bacteria that can cause hemolytic uremic syndrome. We talked about that in the diarrhea lecture. If failure to thrive is suspected in accordance with diarrhea, you'll want to assess for things like cystic fibrosis, IBD, malabsorption, and immunodeficiencies that could be the cause. And then as far as diagnostic imaging or procedures, endoscopy and colonoscopy, we do them in special cases, especially in those where we suspect IBD or where we have kind of unresolved cases. How do we manage diarrhea? The vast majority of cases are going to be fluid replacement, supportive care. So a lot of education for the mom. And for the dad, we always want to go with oral rehydration therapy first if the child can tolerate it. And in small children, babies, we'll want to encourage feeding during and after diarrheal episodes to try to keep them hydrated. There are other tips and techniques we can do to help keep kids hydrated, which we'll cover a little bit later. If they're severely ill, immunocompromised, or if we know that there's some sort of specific bacterial agent, we can consider antibiotics. Breastfeeding is one of the best things we can do to prevent diarrhea and to get those antibodies on board to our pediatric patients. We also have vaccinations against rotavirus, so we want to make sure that our pediatric patients are vaccinated for that. And then just education, proper hand washing, disinfecting food, not cross-contaminating with food, boiling water if needed, hand washing, especially after, taking care of dirty diapers and things like that. All right, so we've covered constipation and diarrhea. Now we're moving on to vomiting, which is our favorite, right? So vomiting is the forceful oral expulsion of gastric contents, right? And so in pediatrics, it's really important to differentiate between vomiting and spitting up. It is really common for babies to have gastroesophageal reflux, GER, not GERD, but GER. It is common for babies to have GER. It's not a disorder or a disease, GERD. You don't add the D most of the time. Most of the time, it's just natural to have some reflux, especially in babies. And so we teach parents how to feed them, burping in between, feeding them upright to kind of reduce the amount of reflux that babies have. This is a list of some of the etiologies for pediatric vomiting. It's not all inclusive here, but these are some of the more common causes, starting with newborns. Some of it has to do with central nervous system. Other esophageal atresias when the esophagus and the stomach don't connect. So as soon as the baby drinks, it comes right back up. Infants can get other things, pyloric stenosis, which we'll cover. We talked a little bit about GERD, allergies, intolerance, overfeeding, lots of things here. And then in the older kids, this is more aligned with what adults can get, including pregnancy. So you have to get a good history when it comes to pediatric vomiting. You want to know, obviously how old they are, whether anyone else in the place of residence has similar symptoms, when they started, how long they've been going on, if they're associated with certain foods. For babies, you'll want to assess the number of wet diapers or urinations per day. That's very important because oliguria is one of the first symptoms that or signs that we see with dehydration. Also can assess for thirstiness if they're asking more for water. Associated symptoms with pediatric vomiting would be the same that we kind of talked about with gastroenteritis picture, fever, URI things, earaches, headaches, abdominal pain, trouble or pain with swallowing, and heartburn kind of symptoms, right? Now, you want to assess the nature of the vomitus. I know this can be kind of gross, right? But you have to get into it, right? You have to ask the parents, is it projectile? If you've never seen projectile vomiting, you've never seen it. Because if you have seen it, you know that you've seen it because literally goes like The Exorcist across the room, right? You've seen that movie. It goes straight across the room. You also want to take note of the color. Is it bilious or not? Is it green, discolored? Does it have blood in it, right? Is it food contents? Is it liquid? Is there a lot of acid? Is it hurt or not? Again, is there blood related to it? And then in severe persistent vomiting, you have to consider CNS because increased pressure, hydrocephalus, meningitis can put a lot of inflammation or stress on the brain, which can cause kind of that vomiting reaction. Okay. Other things, metabolic disorders or derangements like acidosis, alkalosis, things like that, chemotherapy, and then always have to consider pregnancy in older female patients. Physical exam. So fever, we're looking for fever in the vital signs because you can see it in both GI and CNS infections. In babies, we're looking at the fontanelles. So remember we talked about in anatomy those anterior and posterior fontanelles on the skull. And so if we have a patient that is dehydrated, a lot of times we'll see kind of sunken in a fontanelle, sunken in. If we see it bulging or kind of bulging, thinking of hydrocephalus or increased intracranial pressure. We're also going to kind of try to see or observe them feeding, whether or not they have the drive to feed or if they have trouble latching. Of course, signs of dehydration, shock, we have to replace fluids, which we will talk about later on. We're also assessing kind of the overall picture if they have failure to thrive, malnutrition, looking for abdominal distension, tenderness, right? And then pregnancy again. Now, here are the different characteristics of vomitus related to the obstruction. Okay, and this is an example of bilious vomiting. It really is green, just like the color of the gallbladder in our cadavers. Diagnosis. Well, in most cases, if kids are presenting with vomiting, they're vomiting enough that they're having trouble holding down liquids. And so they can get dehydrated fairly quickly. Usually what we start with in the way of laboratory testing is a BMP, basic metabolic panel. And we will go through what a BMP entails. But essentially this is what we would see in dehydration over time. We also sometimes get CK, similar to the CK that we think of with like cardiac enzymes in that little panel. And that's what we get when we're concerned about rhabdomyolysis, which is when you start getting breakdown of muscle because of dehydration. Okay, and in that case we'll see a very elevated CK, and that's in severe dehydration, not only in pediatrics but adults as well. So pharmacologic therapy, we obviously if they're becoming moderately to severely hydrated, we're going to consider IV hydration, and we'll talk about that a little later. And that's for intractable vomiting, severe dehydration, hypovolemic shock. We also want to give the patient something to kind of calm down their nausea. So a lot of times we'll give ondansetron, Zofran. It's our first line, and there are some other ones, but that's the one that we tend to give first line. If we don't have to start an IV, oral rehydration is always considered first line. Even in moderately dehydrated patients, if they can tolerate by mouth, it is actually preferred method of rehydrating. Okay. All right, so we covered constipation, diarrhea, vomiting, and now we're going to talk about fluid replacement in kids. So as we know, with dehydration in both adults and kids, we have to consider fluid replacement. But in kids, it's a little more complicated, and so I wanted to go over that just a little bit. Now, dehydration or hypovolemia, low volume, decrease in total body water, and that's both intracellular and extracellular. It is worldwide a big problem, especially because diarrhea is such a problem worldwide. And here, like we mentioned before, are some of the major causes of acute diarrhea. It's essentially coming from excessive water loss in really one of two ways. Either we are pooping it out or we're throwing it up, right? And sometimes both, right? They can be together. Also, excessive urination, that can happen. And then kids have a larger amount of insensitive or insensible loss, and that's from breathing rapidly, from having fever and effervescing, having the sweating, burns. They have more insensible loss. And then also it can be from decreased intake, right? So if we have anorexia, a lot of kids when they're sick, they have viral illnesses, they just don't have an appetite. And then in other countries and things, we have to consider lack of access to clean water. And a big one, even here in the United States, is neglect. And we'll talk about that when we talk about failure to thrive. So physical exam and history will give you a good idea as to why patients have dehydration, how dehydrated they are, and what we need to do for them. We usually reserve laboratory testing for severe cases. It is traumatic to get an IV and to start a line on a kid to get blood. It can be traumatizing. You have to hold them still. You have to have a nurse or a tech that is really good at getting pediatric IVs. So it's a process. So you definitely don't want to order IVs on every kid that comes in with a few episodes of vomiting and diarrhea. Like I mentioned before, you want to assess for fluid balance by number of wet diapers. How often are they urinating? Are they lethargic? Are they irritable? How many diarrhea episodes or vomiting episodes have they had? And then to assess in physical exam, there's kind of a few things that we look for to determine whether they are mild, moderate, or severely dehydrated. And it's a combination of how much weight they've lost, whether they have dry mucosa, which is one of the first signs here. So dry mucosa. Skin turgor, like I said, that's one of the last things that we see. Fontanelle depression, mental status, whether their eyes are sunken in, how fast they're breathing, what their heart rate is, and then urinary output. It's also one of the first things that we see. All right. We also use a basic metabolic panel or a Chem 7 to assess for dehydration. And we use that depending on what those results show. They will help us determine how dehydrated a child is in conjunction with the physical exam findings. So when you get out into the wards and you start writing notes, nowadays we don't really write notes anymore as much, but back in the day when we would write our labs, we would write them like this. We write, a sideways Y with a couple of partitions here. And that's what we see here. Sodium on top, potassium, chloride, bicarb, BUN, creatinine, and glucose. That is a Chem 7. And this is how we would document it. So essentially normal values for each of these look like this. Have 140 for sodium, 3.8-ish for potassium, 110 for chloride, 24-ish for bicarb, BUN around 5, creatinine 0.2, and glucose around 100. So those are essentially normal values. There is a range, but just to give you an idea. Now, when we start seeing a child with mild dehydration, the first things we start to see change are the rise of the BUN and the fall of the sugar. So it starts going down a little bit. And a lot of times in mild dehydration, that's all we'll see if we see any changes on the Chem 7. Moving into moderate dehydration, we start to see the sodium start creeping up a little bit, okay? We also see chloride creeping up, and bicarb starts to fall. Okay. We also see the BUN continuing to rise. Creatinine is starting to come up as well, and glucose is starting to come down. In severe dehydration, a lot of times we will see across the board problems with the Chem7, including a markedly elevated sodium as well as chloride. We'll see a very, very low bicarb, a high BUN and creatinine, and a low glucose. Okay, and a lot of times you can calculate the anion gap, and you'll be noting that there's a metabolic acidosis many times. Okay, I just wanted to give you kind of an idea of what you're looking for. I don't necessarily expect you to memorize any of these values. So once we've assessed the status of dehydration, how are we going to manage it, right? So in children with mild to moderate dehydration, the first line therapy is going to be oral rehydration therapy, or what we term ORT. And we try to use solutions with similar electrolyte contents to the fluid lost. Pedialyte is great. Breastfed infants should continue to nurse. Try not to use really highly sugary drinks, because they can actually worsen diarrhea. There is also the WHO, World Health Organization, has kind of a rehydration fluid cocktail that they recommend. And then Professor Urbina mentioned a 1-to-1 ratio of apple juice to water. It works really well. The goal is to get the fluids over a few hours to get back to where they were. Other things we can try is giving them syringe feedings or spoon feedings, and in more dire situations we can actually give them rehydration through NG tubes. Usually across the board, give them Zofran. And most pediatric patients that come to the ER that are having minimal amount of vomiting, diarrhea, usually give them some Zofran and do what we call a PO challenge, where we give them something to drink and monitor them to make sure that they're able to hold that down, and we send them home. For those that fail to improve with the oral rehydration, they fail the PO challenge, that's who we should move up or assess for IV hydration. Now, in severe dehydration, it can be bad, right? When we don't have enough blood circulating through our body, we get hyperperfusion. Our organs in our brain are not getting well perfused, and these kids can tank really quickly. The goal is to prevent hypovolemic shock. We got to get rapid volume expansion through fluid boluses. So we tend to give 20 cc's per kilogram over 20 minutes. So that's bolused, kind of getting the fluids in as rapidly as possible. This can be done repeated up to 3 times. And between each bolus, you're going to monitor vital signs, looking to see that those vital signs are improving. Usually normal saline is good, isotonic fluids, sometimes lactated ringers. And then you're also monitoring glucose. Remember we said that we get some hypoglycemia. Sometimes we add glucose to the mix. Now, once we've done the acute resuscitation phase, where we've kind of gotten them back quickly, then we go into the resuscitation phase, which is where we're giving slower replacement of fluids, and that's over days. And so we give what we call maintenance fluids, which I'll show you how to calculate, and we rehydrate them, and we subtract the rehydration phase minus the bolus, and then we give it in 2 phases, one over 8 hours and then one over 16 hours. And then once they become stable, we can just continue the maintenance fluids. So I'm going to show you an example of this. I don't expect you to calculate that on your exam, although I have seen in QBanks this question be asked before. What is the bolus dose for kids with severe dehydration? So like I mentioned, the standard bolus, again, is 20 cc's per kilogram over 20 minutes. It doesn't necessarily have to be over 20 minutes like on a pump, but you can leave it wide open. and that can be repeated up to 3 times. And we're going to monitor the vital signs between each one. That is the bolus. That's to get them started in the acute phase. Then we have to calculate maintenance calculation. And there's a rule that we use called the 4-2-1 rule, which means that for the first 10 kilograms that the child weighs, you'll give 4 cc's per kilogram per hour. For the second 10 kilos, we'll give 2. And for any further kilos after the first 20, we will give 1 cc per kilogram per hour. So let's do an example. A child that weighs 37 kilograms. So for the first 10, we will do it at 4 cc's per hour, which gives us 40 cc's. For the second 10, we will do it at 2, which gives us 20 cc's. And for the third, the rest of the kilos, which is 17 to equal 37, we will do 1. So it's an extra 17. We add 40 plus 20 plus 17, which gives us 77 cc's per hour of maintenance fluids. Easy enough. Let's try another one. So let's say we have a 21 kilogram child. Let's apply the 4-3-2 rule. So the first 10 kilos are times 4. So that would be 40. The second 10, because he's 20, would be times 2, which would give us 20. And then we have 1 left because he's 21. So it would be 1 times 1, which will equal 1, which gives us a total of 61 cc's per hour. And that is for maintenance fluids. Maintenance fluids. Now remember we mentioned rehydration has to do with giving the maintenance plus other rehydration calculations throughout the day. And we also want to monitor the response of the urine output. Okay? And we should see clinical improvement of dehydration. Alrighty. So here's the complete example. Now I'm showing you this just to kind of show you, but I don't expect for you to be able to calculate this from start to finish for an exam. I just wanted to show you. So let's say we have a kid that comes in weighing 25 kilograms. We always do everything for kids in kilograms, so get used to that. They have severe dehydration. So first of all, when someone is severely hydrated, we're going to start an IV on them, and we're going to give them a fluid bolus. The fluid bolus in the acute resuscitation phase is 20 cc's per kilogram, and we can give up to 3, which is a total of, in his case, 1,500 cc's because we're multiplying by the 25 kilos. Okay? Then we have to go into the resuscitation phase, which equals the total amount of fluid equals the maintenance fluids, which we will calculate in a second, plus the rehydration minus the bolus that we already gave here. So calculate our maintenance. Let's do our 4-2-1. We'll start with the first 10 kilograms times 4, which will give us 40. Then we'll do the second, which will give us 20. And the third, which will give us 5, which gives us 65 cc's per hour, or 1560 cc's per day, multiplied by the 24 hours in a day. So that is the maintenance fluids, which we will plug in here. And lastly, we have to calculate rehydration, which it's by 90 cc's per kilogram per day, and that gives us this. So we'll plug this part into this rehydration, and that's how we'll come up with how much we have to give. It's the maintenance times this, or plus this, which will give us this per day. That is what we're going to use. And then remember we said we divide it up into 2 phases by half. And so we give half over 8 hours and the second half over 16 hours. And then we can continue maintenance fluids. So it is quite complicated to be a pediatric intensivist or a pediatric, internal medicine, specialist. But I just wanted to kind of show you how much goes into calculations. You might be doing this in pharm already. Most important things from this would be calculating maintenance fluids and knowing that the bolus is going to be 20 cc's per kilo. All right, so putting it all together, fluid replacement therapy in kiddos. Here is the mild, moderate to severe, and how we replace it. This is kind of the algorithm for that. And then again, to assess from mild, moderate to severe, here are the signs and symptoms we are looking for. The last category that we're going to be covering before we get into the more specific diseases is going to be failure to thrive. Now, failure to thrive is what it says it is. It is when a child has suboptimal weight gain and growth. And so there's several different ways that we can measure failure to thrive and diagnose a child with that. One of which is a drop below the 5th percentile for age and sex, or a drop in the weight that crosses 2 major percentile lines on a standardized growth chart within a 6-month period. And I will show you what a standardized growth chart is on the next slide. Here are some of the multiple definitions that exist for failure to thrive, 2 of which we just mentioned. And it affects approximately 10% of pediatric population. 90% of failure to thrive has to do with a lower socioeconomic status, which is kind of startling, right? To me, it's like all of this is preventable to some means, but it's very touchy. We'll talk about that a little bit more. Some of the risk factors for failure to thrive: prematurity is a big one, intrauterine growth restriction, developmental delay, and some other things here. Here's the growth chart. So every time a child goes in, which is at birth, well, I guess they're already in at birth. At birth, usually 48-hour visit, and then a 2-week visit, a 2-month visit, a 4-month visit, a 6-month, and so on. And those weights and heights are plotted on these growth charts for their age and their sex. And you'll see that it goes up. And so if you see that they are beneath the 5th percentile, here's the 2nd percentile, consistently, that warrants further investigation. Why are they not growing like they should? Another one we said was if they drop two percentages, right? Two lines over a 6-month period, we should consider that. So a lot of times there's some sort of underlying pathology or psychosocial impairment that is the cause of failure to thrive. We have to consider some of the other things that are causing it. Kind of the big groups are one, inadequate calorie intake, which is 90% of cases. It can also be due to malabsorption. It can be due to an increased demand. So we're getting as the calories, but the body's demanding more than we can give it. And then also inefficient caloric use. So those are kind of the major categories. So let's talk about them a little bit more. So again, inadequate caloric intake is 90%. And usually it's inorganic, meaning they are undernourished or neglected or abused. And that it's really sad. But this is very, very common. A lot of times there's family issues, there's money issues, poverty, marital issues, family problems that contribute to this. And it happens much more often than you think it would. There are also some organic problems with patients that cannot take in calories, vomiting, GERD, or gastroesophageal reflux, chronic illness where they're just not hungry, or problems with eating or problems with suction. Then moving on, there's malabsorption. These are things like celiac, cystic fibrosis, milk protein intolerance, chronic diarrhea. There's also inefficient use of calories. So this has to do with some metabolic disorders and things like that. And then last but not least, when the body has excessive demands, and I think of that, the primary one I think of is malignancy, right? But also cystic fibrosis, when you're in a thyrotoxicosis state where you're on kind of hyperdrive, those can kind of demand more nutrients from a patient. Usually we are able to diagnose failure to thrive based on the growth chart comparison. So that's kind of the first indicator. And then from there, we get a better history. We're talking about exposure to certain infections, maternal, cigarette, drug, alcohol use, birth weight, feeding patterns, medications, social, support, caregivers, perception, allergies, supplementations. On physical exam, really first you want to observe kind of the caregiver dynamics, because that can be one of the first things that leads on that a child is being neglected. Is the caregiver empathetic? Do they care about their baby, or are they apathetic? Are they using a proper breastfeeding technique? Other things you want to look for: signs of neglect, unkept child. Are they wearing the appropriate dress for the season? Do they have a horrible diaper rash because nobody's changing their diaper? Keep an eye out for those things. Other things, fontanelle can be sunken in, no tears when crying, muscle wasting, the child is drowsy, and then some other little defects and things that we look for. So once we've gathered a good history and done a good physical exam, we can use some blood work and things and to help us kind of rule in or out certain causes. Like we mentioned, 90% of the time it's going to be just inadequate feeding. And so a lot of times what will happen is kids will be severely malnourished and have failure to thrive. They'll be admitted to the hospital and they'll be fed under supervision. Just kind of watch them and feed them like they're supposed to. Now, if these children do start gaining weight under supervised circumstances, then it's almost certain that the reason why they weren't gaining weight to begin with was because of some form of neglect or abuse, not being fed enough. If under those circumstances, after you admit the child, they do not gain weight, then you have to start looking into some of the more organic causes. Looking for immunodeficiencies, anemias, looking for inflammatory markers, getting electrolytes and things like that, liver function, vitamins, allergy testing, and checking for, cystic fibrosis, celiac. Management, well, because there's a lot going on that contributes to failure to thrive, a lot of times it is a multidisciplinary approach. For the non-organic failure to thrive, the most common, we have to improve the well-being and nutrition of the child, and that has to do with sometimes lactation consultants, dietitians, psychologists, social workers. Anytime a provider suspects abuse at all, they are obligated to report it to child services, even if it's not. If it isn't, if you think it could be, you have to report it. And a lot of times that opens doors for parents who are maybe not abusive but just don't have the services that are needed to take care of children. They'll get the social worker involved and get the child what they need and give the caregiver the support that they need. Hospitalization, like we said, if they're severely malnourished, they're hospitalized. And of course, if you suspect abuse, you have to consider the safety of the child as the utmost importance. For organic failure to thrive, it really depends on what the organic cause is. One other reason why we admit severely malnourished children to be fed parentally initially is because we have to control it. We can't overfeed them initially because it can cause what's called refeeding syndrome. And that essentially what happens is you get a low hypophosphatemia, which can lead to arrhythmias and death. So we have to kind of feed them slowly to get their system back to working and converting the ADP, ATP. Prognosis, well, if we can figure out why the child is having failure to thrive, we can usually get their weight back to normal within 6 months. If we don't treat failure to thrive, though, if we don't catch it, if we don't treat it, it can have long-term sequelae, including severe cognitive developmental delay. They can be short forever, and they can have problems with things like immunodeficiency, inability to create certain antibodies and things. All right, so we've gone through these kind of generalized assessments of pediatrics. Now we're going to go through some of the more high-yield specific disorders in pediatrics. The first of which is a really straightforward. I'm not going to go into a lot of detail on it, but I just want you to at a glance be able to differentiate between an omphalocele and gastroschisis, because at a bird's eye view they kind of look very similar, and so I've seen a lot of questions try to kind of trip you up in comparing and contrasting the two, but we want to make sure that we know the difference. So just based on this picture here, you can see that the omphalocele is essentially intra-abdominal contents, namely intestines, that are trapped in the umbilical cord, kind of the proximal umbilical cord. And these protrude through the ring of the umbilical ring, and they are covered by a thin membrane, which is usually there but sometimes can be ruptured. That's the omphalocele. Gastroschisis, on the other hand, is usually coming out of a hole just to the right of the umbilicus, and it does not have a covering or membrane on it. That's just at a glance. Here's some more differentiation. So omphalocele, we said, is this right here. This is an omphalocele. You'll see that there is a covering to it, and another way to remember omphalocele is it's an O which is a circle that is closed. Same thing here. It is covered is sealed. The contents are sealed in the O. As in contrast, gastroschisis is a G, and it has an opening, and so you can see that the guts come out. So that is gastroschisis. There's some other differences between them. Many of them have to do with prematurity, although omphaloceles can happen at term as well. Again, where they come out is important, whether they come out through the umbilicus, the omphalocele, or to the right of the umbilicus in gastroschisis. They can both be subject to malrotation and inflammation because you have it's intestines that are outside of the body. They're subject to inflammation. And then there are associated anomalies with omphalocele, other genetic issues and anomalies that can make it a more higher mortality and morbidity, the omphalocele. Either way, they're corrected by surgery. And just at a glance, the way that they're described, you should be able to differentiate between one and the other for your pants. Moving on, next we're going to be talking about pyloric stenosis. And you have to remember a little bit of anatomy for pyloric stenosis. Remember, you have the stomach. And at the end of the stomach, before we get to the duodenum, we have the pylorus right here. And in this area, it kind of shuts things off to allow for churning of contents and digestion. And then it kind of opens up and allows food to travel on into the duodenum. Now, certain babies are born with hypertrophy or stenosis of the pylorus. And the reason why I have this picture, this is a very dramatic case. Not all the time do you actually see it with your eyes, but they tend to describe it as an olive-shaped mass in the right upper quadrant, which we'll talk about. All right, so it is hypertrophy of the muscular layer, and basically the liquid is liquid, essentially. Babies drink liquid, milk. The milk cannot get past the stomach, and so it kind of builds up in the stomach, and these patients get this projectile non-bilious vomiting, because remember, bile is secreted into the small intestine, but this blockage is before the small intestine. Usually happens between 2 weeks and 2 months of life, so early on, and we tend to see it in males way more than females, and we tend to see it in the firstborn child. Interesting, huh? Firstborn male child. Projectile non-bilious vomiting, and as soon as these babies vomit, because they lose everything that they just worked so hard to drink, and now they're hungry again, so they get this like ravenous appetite after they vomit. They also can have some dehydration, constipation, and because they're continually vomiting up the acid, the hydrochloric acid in their stomach, they become alkalotic because they're throwing up all of that acid all the time. Again, one of the pathognomonic or kind of high yield facts about pyloric stenosis is the olive-like or olive-shaped mass usually found in the right upper quadrant area, sometimes epigastric. And diagnosis is mainly made clinically. However, ultrasound is the test of choice for this, and also can consider doing upper GI contrast studies. We're moving a lot, in pediatrics, we're moving a lot towards ultrasound. So here's what we see. We do an ultrasound. Here's that pylorus, it's thickened olive-shaped mass. Okay, when we see that, we see this elongated, thickened pylorus on ultrasound. And then if we do the GI, upper GI series, we'll see that area looked like it's cored out, kind of like an apple core or a mushroom, where there is difficult passing of liquid through that pyloric area. How do we manage it? Well, it's surgery. It's usually done as a laparoscopic procedure. First of all, a lot of these patients will be dehydrated, have some electrolyte metabolic abnormalities. So first thing we need to do is correct that and assure that they are adequately hydrated. And then we do a pyloromyotomy, where we make an incision of the serosa, the outer layer, over the pylorus, which is similar to the procedure we would do for, say, achalasia, but in the pylorus area. and that way the stomach contents can pass through. All right, so that was pyloric stenosis. We're going to talk really briefly about duodenal atresia. And I got this double bubble here for a reason. Don't forget it. We're going to talk about it. Duodenal atresia is a congenital deformity of the duodenum. And right in this area, you'll see that it is not cannulized, meaning there's no opening between two areas. So normally we would have this nice patent duodenum. On this side, you see that it is not recannulized. So in the process of forming our gut, at some point it fills up, and then it recannulizes, where it empties out again. And so in these cases, it doesn't ever empty back out, and so we get this area where there's blockage. And proximal to that, because it can't go through, we get distension and dilation of that area. 50% of infants with duodenal atresia are premature, and we see it very commonly or commonly associated with Down syndrome. And so I think of duodenal atresia, Down syndrome, Ds, okay? Don't forget that. They tend to put that in the vignette for duodenal atresia. Also, one other sign on a prenatal ultrasonography, we can see what we call polyhydramnios. And so as babies are in in utero, in mom's stomach, they're constantly drinking the amniotic fluid. But in this case, because they have a blockage, they're not able to drink the amniotic fluid like they should. And so there's a buildup of amniotic fluid. And so we see a lot of hydra, water, in the amniotic fluid, amnios. So you'll see more. And then usually within the first day of life after the baby's born, they will have bilious vomiting, which is the hallmark finding on physical exam. How do we diagnose this? Well, we do prenatal ultrasounds. And in the prenatal ultrasound, you can actually see the double bubble, which is why I said double bubble before, because that is the pathognomonic finding for this. And you'll also see polyhydramnios, excessive fluid. And then after the baby's born, just plain radiography here, you can see the same double bubble, okay, double bubble here. And that is the confirmatory sign of duodenal obstruction. You'll also notice that there's not a lot of air past that area. It can't get past there. So you see no air kind of distal to that. Medical therapy, well, you can do nasogastric decompression, fluid resuscitation, but surgery is the definitive treatment. Moving on, we are going to talk next about intussusception. And this is one that I feel is very important that we know, because you will see it, especially if you're doing emergency medicine or pediatrics. Intussusception is a telescoping of the bowel within itself. And so if you see, this is, let's say, the gut, right? And you get a point where it invaginates on itself. So the gut telescopes, kind of like this kind of telescope where it goes in and out. And because of that, you get inflammation, swelling, and you can even get perforation of this area as it goes in itself, okay? I also have this sausage here. Remember this because we're going to talk about it in a little bit. The most common abdominal emergency in early childhood. Usually we see this before the age of 2 years old, so between 6 months and a year, 2 years old. 80 to 90 are younger than 2. 60% younger than 1, so it's babies usually, babies and toddlers. And it's not always 100% sure how this happens. Usually there's some sort of trigger point that causes the invagination to happen, a weak spot on the intestine. And then once it invaginates, it starts swelling and kind of gets stuck in that area and makes it hard for it to come back out. So textbook, we have a classic triad, and the triad includes abdominal pain, a palpable sausage-shaped mass, which is why I had that sausage before, and current jelly stool. Remember when we were back in the pulmonary module, we talked about Klebsiella causing current jelly sputum. This is current jelly stool. This is current jelly, and this is current jelly stool. Current jelly stool, however, is a late finding in intussusception. So we don't always see it. Even though this is the textbook classic presentation, we don't always see the current jelly stool. So don't rule it out just based on the lack of current jelly stool. Classically, how these patients present and how I've seen them present in the emergency department is this infant or toddler, and they get these sudden onset of intermittent severe cramping where they just kind of tense up. They start crying inconsolably, crying. And they have these episodes. They draw up their legs towards the abdomen. They cry. These episodes last about 15-20 minutes, and then they relax. When the child gets out of that little interval, they can either behave relatively normal, be pain-free, or they can be very somnolent as these episodes progress and become more frequent. And so that's the classic. Kid that has severe episodes of pain, drawing up the legs, crying, then relaxes, and then as it progresses becomes more somnolent afterwards. Also see vomiting associated with it. And again, sometimes you can palpate a sausage-shaped mass. It's usually felt on the right side because the most common area for intussusception is going to be the ileocecal area. So where the ileum invaginates into the cecum. Again, we said that current jelly stool can happen in up to 50%, but it is a late finding. Okay? Sometimes you can have this atypical presentation where the patient just has lethargy and you can't quite figure it out. You have to always kind of consider it. It can be quite tricky because, again, little babies like this don't tell you, my stomach hurts. You have to kind of put the pieces together. Anytime you have a baby that comes in with inconsolable crying, you should consider intussusception. So, typical presentation, like we said, we talked about the history. History helps a lot. The number one diagnostic test that we tend to do is ultrasonography. That is the method of choice to detect it. And what we see on there is what's called a target sign, which I have a slide on the next slide. If we do plain film, it's really to rule out perforation because as time progresses and that bowel becomes more swollen, you can progress to a perforation, which you need to assess for sooner rather than later. If a patient has completely typical presentation and or characteristic findings, we can take them to have what's called either a pneumatic or a contrast enema, and that is where essentially they untelescope the bowel. And that's kind of the reason why I put this little advertising guy. Essentially, they blow up the colon with air, and that de-invaginates or uninvaginates that area. Most of the patients are able to have these procedures done. They're pretty successful, and they don't require surgery. However, if the patient has any signs of perforation or a fever or necrosis of the bowel, then they will have to have surgery. Here's the bullseye or target lesion that we talked about on ultrasound. It's kind of hard to see on this one, but essentially if you have this outer ring, that's the incipient, and this is I can't remember the two terms, but one that goes into the other. Here's a picture of an actual intussusception. So you can see this part is invaginated in there. And then here's a depiction of the target. There's also a really awesome kind of start to finish intussusception case that you can watch. I put the link here for you, or you can watch the video here. It's really nice to see the progression of this kind of in a clinical scenario. Moving on, we're going to talk briefly about malrotation and midgut volvulus. Now, I want to mention that volvulus in and of itself, there are several different areas that the gut can volver. Volver in Spanish is like to return or to come back. And so volvulus comes from that word. And so anytime the gut kind of spins on itself, that is volvulus. Now, in elderly folks, sigmoid volvulus is the most common site of volvulus. For this lecture, we're going to be talking about midgut volvulus because that is the type of volvulus that is most commonly associated with malrotation. Now, when we talk about malrotation means that as a baby is born, they're born with the intestines, this is the large and small intestine, in the wrong place. So malrotation, in the wrong place. So usually what we'll see is kind of the cecum up in the right upper quadrant, and then everything kind of shifted over. And that orientation, that malrotation, puts the gut at higher risk for this midgut volvulus. You'll have to study more of like an embryology and fetal development to understand how the gut kind of does its little foldings and refoldings. Essentially, for this lecture, I'm not going to go into that, but basically the bowel is not in its normal anatomic position. And because of that, there's some fibrotic bands that cover part of the small intestine called Ladd's bands. And this is something that you should remember. Ladd's bands, and those are these right here. These are the Ladd's bands, and you can see how these bands, they kind of impede this duodenum from passing in this area. 70 to 90% of all cases are diagnosed within the first year of life. This is something that's diagnosed very, very early, and because it causes intestinal obstruction due to those Ladd's bands, and sometimes malrotation can cause or lead to what we call midgut volvulus. Midgut volvulus, I think of those animal balloons that are made like at kids' birthday parties, where they twist it on itself and it kind of stays there. That's volvulus. And midgut, kind of along that area, the small intestine is the area that tends to be volvulist when it comes to the malrotation. It can cause severe ischemia and necrosis of the bowel and a lot of issues with that. These patients tend to present early on with bilious vomiting, bloating, distension, and then as time progresses and that bowel becomes necrotic, you tend to get fever, nausea, vomiting, blood-streaked stools, and melena. And then depending on how much vomiting is associated, you can have hydration status become affected. The best diagnostic step is going to be an abdominal x-ray. That should show that things are not where they should be, and it should show the volvulus, if there is one. And these are usually followed up with upper GI contrast series to try to see exactly where the volvulus or malrotation is taking place. So imaging, in malrotation only, without volvulus, the common finding on contrast is to see a dilated bowel on the right side only. Malrotation and volvulus, you'll see what we call a corkscrew or a beaked pattern. And I have some images on the next slide. These are always an emergent ped surgical consultation. These need to be corrected. They call it a Ladd's procedure, and takes out the dead bowel and corrects the anatomic abnormality, kind of repins the gut back where it should. And then they often do a second look, and they're admitted to the NICU or PICU. Here's some pictures. Here's that malrotation, where you can see this large gastric outline with a little bit of just very little distal gas. And this is when you have the volvulus. You'll actually see a corkscrew pattern, but this is not the same corkscrew pattern that we see in the esophagus, as we know that we are much further down in the GI tract. Moving on, we have a couple more disorders to talk about. Next, we're going to talk about Meckel's diverticulum. Okay? So Meckel's diverticulum is essentially the remnants of the omphalomesenteric duct. So when we are in utero, we have a duct that leads from our gut to our umbilicus, and during the fetal development, that duct goes away. But in some cases, we get remnants of it, which forms a true diverticulum. True diverticulum meaning that it contains all layers of the bowel. And this arises from the antemesenteric surface of the middle to distal ileum. We have this rule of twos that we're going to talk about here in just a second. It is the most common congenital GI tract anomaly, and it can cause you can see it in incidents with other malformations elsewhere in the body. Really important, I think, that we remember the rule of twos. And so let's go through them. It occurs in 2% of the population. It is two times more common in males than females. We typically see the first presentation by 2 years of age. 2% of them develop symptoms or complications. The diverticula is usually about 2 inches long and usually 2 feet from the ileocecal valve. All right. That we should definitely commit to memory. Again, it's frequently silent. 25 to 50% of the time, we don't see it. Be less than 10 years of age. Sometimes in adults, we'll actually see it. And we should think about it in cases where we can't figure out where GI bleeding is happening. In smaller children, the most common finding is going to be painless lower GI bleeding. Excuse me. In certain cases, you can get acute, massive hematochezia, or in some cases, you can actually have kind of a more slow, melanotic type stool GI bleed. Other things that can happen because of the Meckel's diverticulum, it can provoke a small bowel obstruction. We can have recurrent intussusception. And then this area, as it is a diverticula, can also get what's called diverticulitis. And they appear very similar to appendicitis. Here is that Meckel's diverticulum. You can see that it should have regressed back into the small intestine, but this is what's the remnants. And then you can actually see it on here and here. So how do we test for it? Well, we do what's called a Meckel scan. It is a nuclear medicine study that looks for the diverticula. There's some other less common tests that can be done, including arteriography, which is more invasive, and CT scanning. But we try to stay away from CT scanning in pediatrics as much as possible because it is quite a high dose of radiation. Other things we can do if we still can't figure out what's going on is a capsule endoscopy or a double balloon enteroscopy. So as we mentioned, for asymptomatic Meckel's diverticulum, in other words, we find it kind of incidentally on imaging. We don't necessarily have to give them any specific treatment. If it's found during surgery for other things, kind of have to consider whether or not to resect it. In children, we recommend resecting it. In healthy individuals, patients greater than 50 with comorbidities. And no resection is recommended if the patient is greater than 50 years of age and there's no palpable abnormality. For all intents and purposes for your exam, they're going to give you usually a kid with painless GI bleeding, and you should from then assess for Meckel's, and the treatment is surgical. It's definitive. Last but not least, we will talk about Hirschsprung's disease. We mentioned it briefly in the constipation section of this lecture. So now we're going back to it. This is a nice image here of what Hirschsprung's looks like. As you can see, we have the large intestine here towards the rectal anal area. We have this area that is not relaxed. It's very tight. And then just proximal to that, we see dilation of the sigmoid colon. This is essentially the anatomical defect of Hirschsprung's, which we're going to talk about. It's a congenital abnormality, and it's essentially an agangliosis of the distal colon. And essentially, we have abnormal nerve innervation to that area, which causes it to clamp down, doesn't relax, and because of that, you have problems with stool passage. Most commonly, it's a sporadic issue. However, there are some associations with RET mutations, which I don't expect you to know too much about. It's also part of several genetic syndromes, which I'm not going to get into. We have men to women ratio about 3 to 4 to 1. But if the entire colon is involved, it's 1 to 1. We also see it more in populations of Asian descent. I'm not going to go too much into the pathophysiology. I think we'll leave that for patho. But you can see that there is this transition zone and this area that does not have nerve function. And it always involves the rectum and then goes a little bit more proximal from that. It can actually affect the entire colon, but that is much less common. As we see here, the most common is a short segment disease. So most that have Hirschsprungs are diagnosed within the first month of life, even more so diagnosed within the first few days of life. Those that have really short segment or really not very severe disease cannot present with symptoms until later on, but that is much less common. So the classic triad of symptoms, the first thing we are going to notice is the delayed passage of meconium. So meconium is that dark black colored stool that babies have, or maybe not hard, but blackish colored stool that babies have in their GI tract when they're born. And so the normal for a baby is to have the passage of meconium within 24 to 48 hours for a term infant. Now, premature infants tend to have a little bit more delay in meconium passage, but the rule is kind of 48 hours or less is what's normal. If we don't have it passing within 48 hours, we should think Hirschsprungs. We also tend to see abdominal distension and bilious vomiting because we have a backup, essentially. Other things we can see is, when we go to do a rectal exam on these patients, we will do a digital rectal exam, and after we remove our finger, we'll have the expulsion of gas and stool because of the release of pressure. Sometimes with a delayed diagnosis, it will present with more of an enterocolitis, and that's because just proximal to that area that is closed off, just distal or just proximal to that area that's closed off, we will see kind of slow delayed transit of stool there, and when stool kind of sits in that area for a long period of time, it can cause infection. You can see sepsis, fever, and even toxic megacolon in these cases. Another thing is that when we have that area, it can act as kind of a turning point for volvulus, and it can cause even appendiceal perforation if fluids get backed up or stool gets backed up that far. Again, there are some later presentations. Usually for your exam, it's going to be this presentation here. If Hirschsprung's is suspected, based on this clinical presentation, we should have some diagnostic testing done. Usually they have a contrast enema where you see kind of this transition zone and dilation proximal to that. And then the diagnosis for confirmation is a rectal biopsy, which shows absence of ganglionic cells. Other things that can do this, manometry and abdominal x-ray, are not as good as those. How do we manage them? Well, for all intents and purposes, we do surgical resection of the aganglionic segment of bowel. There is the ultra short segment, so the really, really small areas, you can do some medical management. However, surgical management is what you think of when you think of Hirschsprung's disease. Overall, we have pretty good outcomes with these. The only problem is when there is a large total colonic agangliosis. they have trouble with incontinence and things because you have to remove so much of the large intestine. And last but not least, there are a lot of associated complications with Hirschsprung's disease. I think if you're familiar with some of the more common ones here, like constipation, enterocolitis, and things, you should be okay when it comes to this. It's also associated with some other urologic and syndrome problems, but for the most part, I would be familiar with the enterocolitis, constipation, and the vast majority of cases that I've seen of Hirschsprung's, I've seen in your pants or in practice questions are related to that early diagnosis rather than the delayed diagnosis. So that was a very long lecture. There's a lot to cover. Obviously, I can't cover every single pediatric GI disorder, but I wanted to hit some of the higher points and some of the more high yield things that I've seen on your examination, on practice questions. I've actually this year kind of revamped this lecture and added a lot more to it because I felt like I didn't know where else you were going to get this. Maybe when you went on your pediatrics rotation, but in those cases you're so busy, in the clinic, learning from real patients that it's hard to kind of go backwards and sit in front of a book or watch a panopto lecture. So I wanted to kind of at least get your feet wet when it comes to pediatrics. Again, pediatrics are their own thing. We treat them differently in a lot of cases than we do adults, and so very important to note those differences and address them. So hope you enjoyed this lecture. If you have any questions, reach out to me and I'll be happy to answer them for you. See you in class.